to introduce to you the moderator for today's debate, a man who graduated in medicine from the Ribeirão Preto School of Medicine at the University of Sao Paulo, did his PhD in medicine from the same university, and currently is the technical director of the Integrated Center for Neurosurgery, which is a post he's held from 2014. He's been coordinator of neurosurgery service of the Hospital São Lucas since 2017. And of course, he is currently the president of the Brazilian Society of Pediatric Neurosurgery. It gives me great pleasure to introduce to you Ricardo Santos de Oliveira. And Ricardo, it's all yours to take the audience through this debate.
Thank you so much, Sandeep. It's a great pleasure, great pleasure to be here today. So first of all, I would like to thank you, the scientific committee of the ISPN, for the kind invitation to participate of this very interesting topic, the 15 Clash of Titans about the total removal of craniopharyngiomas. And it's a pleasure for me to introduce the two titans of today. So I was starting by my friend Guirish Solanki from UK, that will talk in favor of total removal. So Mr. Guirish Solanki is a consultant neurosurgeon in pediatric neurosurgery from the Department of Pediatric Neurosurgery, Birmingham Children's Hospital. One of his main specialty interests is craniofacial surgery. He was the past president of the ISPN meeting in 2019 in Birmingham, and is currently a chairman of the liaison committee of the ISPN. Outside of neurosurgery, his other passions are playing chess and development of artificial intelligence software programs. It's interesting. He enjoys music, dancing, and play basketball. I don't know if it's true. So on the other hand, we have Todd Hankinson from US that will talk against total removal, more conservative. Todd is Associate Professor of Neurosurgery and Pediatrics in Children's Hospital, Colorado, and the University of Colorado. His interest is in pediatric brain and spinal tumor, and also pediatric cervical spine. His primary interest is craniopharyngioma. He has several papers, and he participated in the group of research for different therapies for pediatric craniopharyngioma. Both are members of the ISPN, and Todd, he likes to cycle, ski, play soccer, and travel. So congratulations, and it's for yours. We start for Guirish, in favor.
Oh, sorry, Ricardo, it was the other way around. Todd is going to start. And
Todd,
since the motion is total removal is necessary, Todd is going to be speaking first.
Okay.
Thank you all very much. Thanks, Ricardo. Thanks, Guirish. Let me just share my screen. Everybody see that okay?
Perfect.
Perfect.
So again, thank you very much to the Education Committee and Sandeep. And so I'll be speaking in support of the idea that total removal of craniopharyngioma as frontline therapy is not necessarily the ideal treatment for all patients with craniopharyngioma. But what I want to do first is establish the fact that what this really is an unabated assault by Guirish on colonial shores by British powers that feel like they have lost their influence in the world. And I think that it's not about craniopharyngioma, it's really just about influence. And I don't normally use like definitions of terms in these debates, but I think in craniopharyngioma, it's actually particularly relevant because each craniopharyngioma is a little bit unique and each patient is really unique. And so it really does, in terms of your first line decision-making, depend upon the judgment and skill set of the surgeon who's involved in caring for the patient and what she or he feels is the right thing to do. So one's conception of the right therapy actually is really important in these patients. And when it comes to GTR, unfortunately, what may be desirable is not necessarily very likely to become reality, which is removing the tumor and having a patient who's neurologically intact. And again, I think that you can't reinforce enough the fact that each individual patient is a different situation. So for example, this patient with this scan who presents at 2 years of age with just headaches and is neurologically and endocrinologically normal may require a very different strategy where you try not to be super aggressive because you don't want to cause endocrine problems in a very young patient versus, and in her case, what we did was basically just be very conservative and initially just drain the cyst, and she remained endocrinologically intact. Whereas if you have a patient who already comes in pan-hypopituitary, they're a little bit older, the exact same tumor, you may want to treat with a much more aggressive approach. So I'll come back to this idea that the ideal therapy is very much dependent upon the patient and situation that you're in at the time. And therefore, gross total for everybody does not necessarily make sense. And just to really quickly lay some groundwork, most of us are probably fairly familiar with some of the basics of craniopharyngioma. I think what's relevant here and what sort of seeds this debate is the fact that craniopharyngioma is a histologically benign WHO grade 1 lesion. So ostensibly, it should be curable. You should be able to take this thing out and it should be cured because it's not a malignancy that is known for metastasizing or growing really quickly. I'll talk a little bit about some of the evidence that shows that it's not as curable as we would like it to be with surgery, which I think is a big part of the reason why GTR is not always the right way to go. And I do need to apologize a little bit to people like Uta Bartels and Sergio Caballero, because I'm really going to focus this on the debate around gross total resection versus subtotal and radiation, and not talk a lot about other therapies which are out there, like intracystic first-line therapy, for example. And at the end, I'll talk a little bit about some of the biological targets that are emerging, because I do think those are relevant to decision-making, especially in some of our younger, healthier patients. So when you start talking about craniopharyngioma, the other piece that I think is critically important is how you think about the overall trajectory of your patient. It's not just plucking a tumor out. What these patients have is a chronic disease that's going to affect them for their lifetime. And whether it's the tumor growing back or the impact of the illnesses that they have as a result of the tumor or the therapy, you've got to really think about these patients as having a chronic disease that we need to try to help them manage throughout their childhood and into their adulthood. And this is just an example from our clinic. This growth chart on the right shows how a patient's weight can absolutely explode after they're diagnosed and treated initially for craniopharyngioma. And that has huge impacts down the road in terms of both quality of life and in terms of the length of their life, which we'll talk about a little bit. And it's been shown multiple times by multiple groups that the quality of life of patients with craniopharyngioma with the therapies that we use today is very significantly impaired, worse so than any other tumor that we take care of. And that's something that always has to help seed the way we think about how we take care of these kids. So how is tumor control with regard to gross total resection versus subtotal resection? Well, how is tumor control in general? And relative to other tumors that we take care of, tumor control rates in craniopharyngioma are pretty good. They're not great, and there's a little bit of conflicting data, but they're pretty good. And that's important because what it says to us is, we have ways to control tumor growth. And so both multi-center international data from the craniopharyngioma group based in Germany, report from Liverpool and multiple other places demonstrates that tumor control rates, overall survival rates, certainly in the short term for craniopharyngioma, are very high. So we can, generally speaking, control these tumors, which reinforces this idea that what we need to do is optimize quality of life. And so the question in this debate is, how do we get to optimized quality of life? Because tumor control rates are okay. And if we're trying to frame this between GTR and STR with radiation, a lot of the debate is really, what's the morbidity of GTR versus the morbidity of radiation? And again, to kind of reinforce this point, what you can see from data from multiple centers, multiple countries, different continents even, is that with radiation therapy, you can get tumor control rates that are satisfactory, if not completely equivalent to gross total resection rates. So these reports show that basically you can get upwards of 89, 90% tumor control at 3, 5, 10 years And that's the same or better than what you can get with gross total. And there's, I would say that on balance, the argument is that your tumor control rates are the same, whether you're using gross total or subtotal and radiation. So then in that context, you say, okay, well then why would I lean towards gross total? What about it makes it preferable? What makes it ideal? And number one to me would be, well, if you can cure the tumor reliably, then go for it. And number two would be, well, if you can't, is it safer than what your other options are? Is gross total resection a safer approach than STR and radiation? So let's take a quick look into some of the evidence with regard to those two questions. So first, do you cure the tumors with gross total? I just showed data that said that we have really good control of these tumors in terms of their growth. But what you see from a number of different publications, and again, different places, different approaches to the research, is that gross total alone doesn't actually get cure rates that are as good as we should achieve and as we think we should achieve. So here, this is again, multi-center data, multiple countries. So this is kind of a generalizable data set from people with different levels of experience. And what it showed was that in the complete resection group, at 3 years, 36% of patients had had progression. So that's a pretty astronomical number for a tumor that we think we should be able to cure with gross total resection. Now, I don't want to overspeak, right? Because incomplete resection had an even worse progression-free survival rate, but those were patients who in many cases, didn't have radiation, and they were waiting to treat with radiation until the patient progressed. So that number is influenced by the management algorithm. But in terms of just GTR, you had 36% who failed within 3 years. And looking from a different data set that came out of Germany with really long-term outcomes, what you saw, again, was that progression-free survival was only 48% when you got out to the 10, 15, 20-year range. So again, gross total resection is not curing these patients. And so you've got to think about the fact that they're going to need many of them are going to need additional therapy even after you've put them through the risk of a gross total. And how does that marry with the idea that what we're trying to maximize here is quality of life in a chronic disease? And I think this point is reinforced by even series from like truly experts, master surgeons who are doing these operations still have failure rates that are higher than what we would want. So here the group from NYU had a 20% failure rate after gross total resection. So it's not just an issue of people with little expertise or not that much experience who have patients who have a GTR and recur. It's even the best surgeons in the best centers with the most experience still have fairly substantial rates of recurrence after GTR. And in addition to that, I think one thing you can take from this particular paper is these operations are difficult and potentially very dangerous. A 3.5% perioperative mortality rate is something that is a significant rate. And most of the surgeries that we do don't have mortality rates like that. So this is GTR not only fails, but there's also it's a technically challenging thing to undertake and potentially extremely risky for patients. And so it's not something that should be taken lightly or something that we should say we need to do in every patient that we take care of. Now, that being said, the NYU group concluded that it was still better than less aggressive approaches. So I don't want to say that, it's not ever the right thing to do, but I think that it really needs to be taken, with some of these data in mind. So, I would argue that GTR does not necessarily cure the tumor. And so let's take a look at this idea that it's safer, because even if it doesn't cure the tumor, if the rates are the same as STR plus radiation and GTR is safer, then that's still a good argument for GTR. So here we start to look at some more multi-center data as well. So this was a lit review that came out of UCSF a few years ago that basically demonstrated that when you compare GTR to STR and radiation, there are specific areas where GTR is more likely to have more morbidity. And where that really is in new endocrinopathies. So what they reported was a 2.5 times the rate of new endocrinopathies with GTR versus STR. When you look at other aspects of things, for example, neurological complications or visual deficits, it was pretty much on par, GTR and STR. So when it comes to some things, they're the same, but you still can expect a little bit more in terms of endocrinologic injury after attempts at GTR than more conservative approaches. So in that regard, it's not necessarily safer. And when you look at other series, both single institution and lit reviews, you really sort of see the same thing. You see that when it comes to endocrinologic dysfunction, panhypopit with DI, you tend to see more of it with more aggressive surgery. Maybe in some series you see a little bit better outcomes in terms of vision with GTR. That's not universally true. The Boston group saw basically that they were on par. So what is clear from these data is that GTR is not safer than STR. Maybe it's about the same, or you can expect some more endocrinopathies. And is that really worth it if you're not actually getting better outcomes? I think the argument is that it's not necessarily. So to say that it's ideal when you don't get better outcomes and you do have more morbidity, I think doesn't make a lot of sense. So then where does that put us right now? And you know, people talk a lot about, you know, the pendulum has swung towards less aggressive surgery. And on some level that's true, but it's not universally true. So I think that, you know, these are papers from highly experienced centers who really think about how to treat these patients. And what I would argue unites all of these conceptually is that the approach to the patient needs to be nuanced, that every patient is unique and you need to think about what tools you have and what clinical situation you're in. And in some circumstances, to be honest, GTR is the right approach, but in many circumstances, it may not be. And so limited surgery is something you need to think about when you're making decisions about how you want to initially treat your patient. And what's the thing that should help guide decision-making with regard to when you're aggressive, when you're not aggressive? And that becomes a very complicated conversation. But to me, the work from Stephanie Pouget and Christian St. Rose from 2007 was hugely influential in the surgical world because it brought to our attention this idea of hypothalamic sparing surgery and the fact that you need to really think about the hypothalamus and how the tumor impacts it, how your intervention can potentially impact it when you're planning your approach. Now, I was a little bit shocked when we kind of like reviewed this particular grading system that the inter-rater reliability wasn't very good, but I think that doesn't change the fact that conceptually, this was a hugely important thing for surgeons to understand, that really the first point to think about when you're deciding what your approach is going to be is injury to the hypothalamus. And this concept has been reinforced again multiple times over many years, I think very elegantly with long-term follow-up by Hermann Mueller and his group from Germany that looked at quality of life outcomes and really sort of like functional important aspects of life, like, you know, what percentage of people who have hypothalamic injury are married, have a life partner, have children, have driver's licenses. Things that really impact us every day are really affected when you have an injury to the hypothalamus, whether it's by the tumor or by your intervention. And one thing that I think, you know, Guirish will probably talk about, and we probably don't talk about enough, is the impact that the tumor itself has on the hypothalamus and our normal neurological function. So the step that sort of makes me think about is, well, is surgery really the ideal treatment at all, GTR or STR? I think that we've come an incredibly long way, and I think that the UK group, you know, this particular paper is from Liverpool. This is a really sophisticated, thoughtful approach to how to treat a newly diagnosed patient with craniopharyngioma. And I'm not sure that we're going to get a whole lot better than something like this with the approaches we have with surgery, you know, whether it's limited, whether it's GTR. So have we potentially, or are we approaching sort of a ceiling in what surgery is really going to accomplish for us and what surgery plus radiation is going to accomplish for us? And should we really be asking the question, do we need to think about different modalities and approaches? And so I'm just going to quickly run through some of the things that are going on from a tumor understanding standpoint. And there are, there's a lot of work coming out now from a number of places looking at the biology of these tumors. And JP Martinez-Barbera and John Apps and their group in London has done awesome work and continues to with genetically engineered mouse models where we're able to really study how these tumors grow, where they come from, and with that, hopefully design some targeted therapies that are going to help us maybe approach these tumors in ways that we haven't been able to do before. And so we've known for a while that craniopharyngioma, adamantinomatous craniopharyngioma, is really characterized by a mutation on chromosome 3 of basically leads to a non-degradable beta-catenin protein. How exactly that translates into pathogenic behavior, we're still working out. But on the genetic level, that's really the only known aberration that these tumors have. And when you look at gene expression, what you end up seeing is really high levels of inflammatory markers in these tumors. You see upregulation of pathways that indicate that senescence-like behavior is happening. You see evidence that these tumors sort of mimic tooth development in a lot of ways. And so we're increasingly starting to see data that may give us some guideposts to finding new therapies that we can actually use for tumor control rather than just relying on surgery with some combination of radiation or not. When you look at protein expression in these tumors, what you see is a lot of pro-inflammatory markers. You see, again, markers of senescence, and these things can potentially be approached with therapy. So what we happen to do in North America right now is we have a small consortium where we share tissue, we share quality of life outcome data, we share neurological outcome data to try to learn more about what correlates with poor outcomes in these patients, be it biologically, clinically, quality of life, to try to see if we can identify new therapies. Some of the cool things that have come out recently is there's evidence that the adult adamantinomatous cranio and the pediatric adamantinomatous cranio are very similar on a gene expression level. So that's nice potentially, because therapies that we come up with in kids, we could potentially then translate to adults or vice versa. There are data now that indicate that the IL-6 receptor inhibitor tocilizumab actually manages to get to craniopharyngioma after systemic administration. So this implies that craniopharyngioma doesn't actually sit behind an intact blood-brain barrier, which has really significant impact on what therapies we might be able to use. We may not have to worry about getting across the blood-brain barrier when we think about systemic anti-tumor therapies for craniopharyngioma. That's very different than normal other brain tumors that we have to think about. And there's some clinical evidence to support the use of IL-6 receptor blockade in craniopharyngioma, the use of MEK inhibition in craniopharyngioma. And so as a result of that, we're starting to see some clinical trials that are being developed. So the CONNECT Consortium has a trial in development that should be opening in the next few months of therapy with one arm that's IL-6 blockade, one arm that's MEK inhibition, and then a combination arm. The Pacific Pediatric Neuro-Oncology Consortium has a trial that's in development that's going to use PD-1 inhibition based on some data that I didn't have a chance to talk about, and JP and John Apps's data that demonstrates that MEK inhibition may be effective in these patients. So again, there are new trials that are coming out that leverage recently discovered biological characteristics of these tumors, and there's a whole menu of potential novel therapies coming out for these. And so the reason why that's relevant to this debate is if we're hurting patients, if we're making them pan-hypopit, if we're damaging their hypothalamus with super aggressive surgery, then these treatments aren't going to help those problems. And if we can be thoughtful and careful and minimize the injury to these patients initially, there are a lot of new therapies coming along that may effectively manage these tumors without causing the types of neuroendocrine damage that we unfortunately are used to seeing with craniopharyngioma. So the way that I would conclude is that GTR is not the ideal treatment because there is no ideal treatment for craniopharyngioma right now. It's a nuanced decision that really depends upon the characteristics of the patient and to some extent the surgeon who's taking care of them. And what we need to think about is cranio as a chronic disease where we're really trying to keep quality of life as high as possible, especially in the context of the fact that there are new biological insights that are going to be able to be translated into potentially effective anti-tumor therapies, potentially in the relatively near future through some of the clinical trials that are developing. So in my opinion, the sun has set on the empire of gross total resection, and Guirish is going to have a very difficult time spreading that empire back again, given what we know about these tumors. And there are sort of too many people for me to thank with regard to the work that gets done around craniopharyngioma. But again, I want to thank the Education Committee for ISPN and Guirish for participating in this with me.
Thank you, Todd. That was wonderful. I'm just going to start sharing my presentation. I have to tell you, I'm the last person to try and colonize any individual or country, for sure. But thank you for those thoughts. Makes me a bigger titan, I suppose. A nasty one, though. Okay, so Absolutely. I think everybody would, what you said would resonate with the current sort of approaches to management, treatment of craniopharyngioma. I congratulate you on an excellent support of that thought. Can I just ask whether my slide are sharing at the moment?
Yeah, you just need to go on onto the full screen.
Okay. Okay, is that all right now?
Perfect.
Okay, so first of all, Sandeep and Ricardo, thank you very much for the consideration of having me to defend what is increasingly controversial and contestable and colonizing and aggressive Titan behavior of total removal of craniopharyngiomas as the ideal treatment. Yes, but of course, I think it's always good to research a position that you may not practice, because that is how you learn the other person's view. And absolutely, Titan sitting together provides an opportunity for the audience to understand where we're coming from and what are the things that we must ponder so that we reach a medium. And I count on Ricardo to help us with that. So I have no financial disclosures. Craniopharyngiomas is very well known to you, and I thank Todd for the introduction. So I'm just going to move very quickly on some of the slides, which is really just to bring in that what we are going to talk about today is pediatric craniopharyngiomas, the adamantinous type, which more recently has now been identified as having features, not dissimilar to tumors, particularly the beta-catenin mutation, the inflammatory response, particularly in the cystic tumors, and the targeted biological therapies that are beginning to come into view for potential treatments in the future. The imaging, this is something that one of my colleagues at the Children's Hospital shared with me, John Abs. This is one of his slides. The rule of 90s seems to be interesting, although I think with MRI scans, it's not 90s anymore. And the clinical presentation is, I think, well known to everybody. But what I wanted to bring to your attention, and this is why I put this slide, is that all of these children that we say have morbid obesity and all of that, they unfortunately already have that for quite some time before they present, and that continues. And I'm always reminded of the fact that, for example, when we see somebody that comes with myelopathy, they do have myelopathy for quite some time before you actually end up identifying them and operating on them. And after surgery, even though there is improvement in the change in the signal within the spinal cord, the myelopathy doesn't disappear and may actually continue. And then, we would end up complaining about the surgeon's, the surgical intervention as causing myelopathy to deteriorate. But I think that there is an intrinsic pathology that the disease has caused that continues inexorably, whether you carry out interventions or not, and we must be reminded of that. We are, of course, very concerned about the significant hypothalamic and pituitary damage that this tumors cause, and in surgical interventions, or the treatment burden, as we call it, give these patients. And we must, of course, remember that, and Todd has made a very important demonstration of that. Children will die mostly of that, and cardiovascular events as well. And I'm very grateful to my friend and colleague, Jeff Wissoff. He shared this slide with me, the craniopharyngioma status score, which was published nearly 10 years ago. And I think this provides a mechanism for us to quantify the 5 important variables in the treatment of craniopharyngioma, which is visual deterioration, endocrine dysfunction, hypothalamic function, and of course, in the long term, the academic performance and development in terms of cognition. So we get to management. So, and particularly, quite consistent with the Titans Clash today, is the most controversial of all CNS types. Treated options, of course, are simple: surgery, radiotherapy, intercystic therapy, novel therapies coming up, creating this triangle. And my colleague, Conor Malucci, shared the slides with me about the paper that Mark Steinbach published the initial data suggesting that mortality, morbidity, hypothalamic damage, visual deterioration is significant in this tumor, despite aggressive tumor resection. And also that although surgeons felt that they were doing gross total resection, in fact, most of them were not gross total resections. And almost there was a constant complication ratio of diabetes insipidus, hypopituitarism. So we are all very much reminded of that. And of course, as a result of that, there was a feeling that we should start changing our approach and try to consider avoiding removing the tumor around the hypothalamus to avoid the most serious effects, try to preserve the pituitary stalk. And a number of papers then followed with that in mind. And Connor and his colleagues in Liverpool wrote on the introduction of the CCLG guidelines, risk assessment grading, which I will refer to a little bit later on. So at this point, of course, the pendulum had swung very heavily in the direction of limited surgery or partial resection rather than aggressive surgery, and very much so given the results of many papers coming up. So I'm also reminded, well, what do we want to do with craniopharyngiomas? We just want to get a diagnosis and then go straight for radiotherapy treatment, or do we want to actually remove the compressive element that this tumor has around the chiasm, around the pituitary, the third ventricle, the hypothalamus, and visual failure that ensue due to compression? What are our goals? And what is the gold standard of treatment of craniopharyngioma? And I think Jeff Vissoff has put it best. And I will refer to his approach on this as well. So significant amount of data came from the craniopharyngiome. And here we can see that in that particular study, multi-center study, most of the tumors were carried out in centers. We're performing very few operations per year. So one patient in 6 years, small sized, 2 to 5 patients over 6 years, middle sized, and large size, more than 5 patients over 6 years. So this sort of centers provided the data for the craniopharyngiome study. And essentially 70 to 80% of the patients received treatment at low volume centers. It was a prospective multi-institutional study, but there was no uniform treatment strategy. So it wasn't that there was a plan that everybody followed. And the question really has to be asked, are we, looking at results from inexperienced surgeons, which carry out surgery very occasionally? Do you think that that sort of standard of surgical expertise would be comparable across centers with more experience? And so these are the questions I think that everybody would have to ask. But from that study, we got a standard. And the standard is that the overall survival about 20 years is about 80%. And the progression-free survival also is somewhere around 70 to 80% between 10 to 20 years. And that is using all of the modalities of treatment. So can we then, the next question, can we identify preoperatively the good risk and the high risk children? Because if we can do that, then we can quite easily say, well, this is a good one for me to do gross total resection, and this one is probably not ideal for me to do that, and I should attempt other strategies. So here comes Christian St. Rose and Stephanie Pouget, who in 2007 published their classification of evaluation of the hypothalamus in the craniopharyngioma surgery and how to avoid hypothalamic injury. You can see here that they have 3 grades, 0, 1, 2, and the preoperative images, you can quite clearly see that in grade 0, the tumor does not come anywhere near the hypothalamus. The floor is quite visible. In grade 1, it is separate from the tumor, and grade 2, it is indistinct from the tumor. Therefore, grade 2 is the one that raises the greatest risk of hypothalamic damage in an attempted gross total resection. So based on that, it was then possible to make recommendations. And this is a nice sort of algorithm chart that kind of suggests if you have raised intracranial pressure, and there is a cyst, then you attempt drainage of the cyst. And if you have grade 0 or grade 1, then it is possible for you to consider a gross total resection. Otherwise, you should consider either a partial resection or subtotal resection in the higher grades. And that was a recommendation that was positive. It added to the surgeon's decision-making intraoperatively and preoperatively, and allowed us to continue to look at how we could make improvements in the way we carried out surgery. Of course, the other treatment options would then be used either in combination. So either you do radical surgery, irradiation plus partial resection. So there were the other options that were there, and you would use them then considerably or consistently depending on what you found. The craniopharyngioma really is a benign tumor, but has a high mortality. So, it is something for us to worry about, and the recurrences occur even after gross total resection. So other alternatives started appearing on the horizon, and intracystic chemotherapy certainly was one. And then the modalities of radiation, including proton beam therapy, and then the consideration whether we should be looking more closely at various types of surgery. I think it's pretty much clear now that interferon treatment, of course, may dry up the cyst, but it's not a definitive treatment. So what do we have? What we have is a strategy where you have a benign tumor, which is not a brain tumor. It arises from the embryonic remnants of the cleft, Radke's cleft, and rises up, lifting the dura, lifting the arachnoid towards the brain. And unfortunately, it's the most critical part of the brain. So either you get the opportunity when you first see the tumor, a virginal tumor, to attempt a total resection of the primary tumor at that stage, and then observe if you got a gross total resection, and if you had a partial resection, then consider radiotherapy. And that, I think, would be the goal of surgery, particularly in those tumors where the grading is satisfactory. So the conventional wisdom, and this is again, I'm grateful for Jeff Wissop to share this slide, is younger children have a worse outcome with radical surgery. Giant tumors have a lower rate of total resection, higher incidence of recurrence, and more postoperative deficits. And residual calcifications increase the risk of recurrence. The postoperative hypothalamic dysfunction and obesity is inevitable and leads to poor quality of life. So this is in primary craniopharyngioma, the conventional wisdom. Now, is that really true? So there are a lot of things that we take for granted, and I think a systematic study may not show that to be the true case. So again, you need to consider whether the tumor is primary or recurrent, impact of age, tumor size, and a number of authors are coming forward and are saying, look, you need to grade these tumors by their size, because if you have a small craniopharyngioma less than 2 centimeters, why would you not do a gross total resection? Why would you then have a strategy of partial resection and radiotherapy on a small tumor like that? But if you have a tumor which is more than 6 centimeters in size, maybe calcified, perforating through the floral hypothalamus, then clearly you will have to have a different strategy. So grading by size is something that is being pushed forward more and more. And one of the gradings is less than 2 centimeters, 2 to 4 centimeters, and 4 to 6 centimeters or greater. And then what's the acute and late morbidity? So these are the sort of questions that we really need to answer more adequately. Now, in the UK, way back in 2005, the craniopharyngioma guidelines came into practice, and we all followed that. And we had, therefore, 2 different groups, the good risk group and the poor risk group. The good one was, again, as I said, a small tumor, no hydrocephalus, no hypothalamic syndrome or breach of the third ventricular floor. And the poor risk was the one with all of this, retrochiasmatic in nature with hydrocephalus, hypothalamic syndrome, or breach of the third ventricle. And for the good group, we would then consider radical surgery. For the retrochiasmatic and large tumor group, we would consider limited surgery and radiotherapy. And then carry out postoperative MRI assessments, and then you reassess whether you need to complete the excision or continue with radiotherapy and so on. So this was something that became pretty much consistent. And then it provided a balanced sort of approach with regards to curative surgery versus protecting the patient from hypothalamic and endocrine injury. And I'm sure that that made a difference. And Stephanie Pouget then published her data as well, looking at the grading, which I already mentioned. Conomolucci and the Liverpool group added to that grading the additional points for hypothalamic syndrome, hydrocephalus, breach of the third ventricle, tumor size. And that, I think, certainly helped us clarify the good, the bad, and the ugly craniopharyngiomas. And I'm always reminded of Richard Hayward, who taught me about the good and the bad and the ugly. A very nice sort of a way to describe craniopharyngiomas. But really, how do you separate the bad and the ugly, and how do you make the bad into a good is in the detail. And I'm grateful to Connor for sharing the slides here. For example, here's a patient with craniopharyngioma with enormous cystic expansion, making this craniopharyngioma look like a giant craniopharyngioma. What he did essentially, he carried out endoscopy, drained the cyst, was then able on a follow-up MRI scan to identify the floor of the third ventricle and then carry out the gross total resection of the solid tumor. So this then allows us an alternative pathway that a grade 2 at the beginning at presentation can be converted to grade 1 and then surgery carried out on that. So this is one example. Here's another one, a patient presenting equally with large cystic expansion. So these patients can have their groups reduced by initial pre-surgical, or what I mean, a gross total resection surgery, endoscopic surgery, and then once we are in a position to do surgery, then carry out surgery. So I can give you lots of examples of that so that we can improve the risk group, reduce the risk group, and then consider surgical intervention in a more aggressive fashion so that the gross total resection can be carried out while preserving the hypothalamic structures or the floor of the hypothalamus. Here's another patient, severe loss of vision. MRI showed the probable craniopharyngioma of surgical removal. Patient undergoes first surgery, the bulking is carried out. Then a second surgery carried out to take out more tumor. The patient is now ready to go for proton beam therapy, but again develops a further rapid large recurrence. Third surgery is carried out, and then he goes for proton therapy. And you can see that in this case, the floor of the third ventricle is still preserved. Case after case, you can see that you can improve the grading of these tumors by systematic support and control of the structures. And the idea is really that you want to protect vision. That's why you're doing the surgery. You want to stop vision from getting worse. You want to take the pressure off, treat the hydrocephalus, and then protect the hypothalamic region. So those, I think, once that is in your mind, and of course, the last one is pituitary stalk, whether you should preserve it or sacrifice it. And I think that is a question mark. So what is the philosophical assumption if you want to carry out a gross total resection? And I've shared, this slide was shared to me by Jeff Wissop, who is one of the surgeons who support gross total resection in craniopharyngiomas. So the pediatric craniopharyngioma should be treated by curative resection because the first is the best chance of cure at the time of presentation. And all children should have pre-treatment consultations with neurosurgery and radiation oncology as a multidisciplinary approach. If you're planning to do radical surgery, then you must have socioeconomic support for postoperative management of endocrine deficiencies, because they're going to have that. A radical resection provides good quality of life in his experience, and his data proves that. And of course, the most important thing is experience matters. He shared this data on his series, 172 operations, 146 patients. I won't go into all of the details, but you can see that it's a very good balanced series. The locations of tumors were everywhere: intracellular, prechiasmatic, retrochiasmatic, complex, even ectopic tumors, and in the third ventricle. His main approach was stereonal, 95% of the surgeries, 8-stage procedures. So what he's saying, well, you don't have to take the whole tumor in one go. You can do 2 or 3 procedures. So if you stage them, then you might have a better chance of getting the whole of the tumor. And his microsurgical dissection was quite meticulous in detail. So he did a wide dissection of Sylvian fissure, identified the vascular structures, identified the optic apparatus, arachnoid dissection, internal tumor decompression, removal of capsule. So, and this is a series of images of patients where he carried out gross total resections. And you can see the amazing surgery that is performed with preservation of the floor of the third ventricle, hypothalamus. You could say that, you know, there's hardly any evidence that he's been in there. Again, another, this is a grade 1 Puget, where the floor of the hypothalamus is not involved. Most of those are prechiasmatic tumors, of course. And is a, you know, event, so this is primary versus recurrent, progression-free survival. You can see the difference quite clearly, that primary tumors clearly do better. Again, more data, less than 5 years, recurrent less than 5 years. In essence, what I wanted to point out to you is that you can have a gross total resection with very good progression-free survival, and these are patients without radiotherapy. Even in giant craniopharyngiomas, the primary tumor resection does significantly better than by leaving tumor behind and then going back after recurrent tumors. So some of the things that we believe to be true, our conventional wisdom, does not stack up when you actually carry out consistent, high-quality gross total resections in a center that is consistently getting good results. This is the SF36 evaluation of the basic metabolic index in these patients. And if you see the patients underwent craniopharyngiomas, or the study population, are in light blue, the dark blue is normal population, and Jeff's series points out that there is no statistically significant difference between craniopharyngioma patients and the normal population on a 20-year follow-up. So I accept that, you know, the pendulum has shifted, but we are looking at significant data, not 10 patients, not 20 patients. We're talking about nearly under 200 operations on a large center with 30-year follow-up, providing an alternative data set that is one of the best in the world. So here is what we look for. What are our concerns when we do craniopharyngioma surgery? We look for neurological deficits post-op, visual, pituitary, endocrine deficiencies, hypothalamic dysfunction, and educational analysis over a long-term period. If you put that against the age of the patient, the size of the tumor, the recurrence of the tumor, hydrocephalus, the location as retrochiasmatic, and the preoperative, the craniopharyngioma score that I showed you earlier, this is the data. The surgeon's experience is another one that is significant, and that has not been discussed on a regular basis. So I think, you know, if you look at this, recurrent tumors, giant tumors, and the preoperative score are the salient features. And this is why I keep coming back to the elephant in the room, and I mentioned this to Todd, is that I think that a lot of the stuff has already happened. The disease process is inexorably continuing. Despite the best attempts of the oncologists and the surgeons, you will continue to see deterioration. The deterioration will be aggravated by the interventions which bring additional injury, no doubt about that. But I think we must remember that a lot of what is happening is exacerbated by the disease process. Now, the surgeon's experience was clearly evident, particularly in the areas of causing less neurological deficits, less hypothalamic injury, and improved educational performance. And I asked Jeff, how do you do that? How do you evaluate the surgeon's experience? And what he's told me is that every 5 years, so it's a quantile assessment, as you can see here, it's a quantile assessment. Every 5 years, he looks at the operations he's carried out, and he looks at the outcome of that group. And he's identified that in the areas, you can see that A stands for neurological, B for visual, C for is endocrine, D for hypothalamic, E for learning activities, educational and occupational. So in every one of those, he was able to identify whether he had got better or not. And clearly for him, he didn't get better in visual scores. And that was, I think, one of the things he pointed out. And the second one was pituitary function. But when it came to motor deficits, hypothalamic, and educational, there was definitely an effect of improving experience in the outcomes that he himself evaluated consistently. So in his series, over 90% of primary craniopharyngiomas, 90% of primary craniopharyngiomas were cured by single gross total resection surgery alone without radiotherapy, with a good quality of life. The safety net is necessary for long-term hormone replacement, and that goes without saying. So overall, disease control can be obtained in 95% of patients with primary surgery, secondary surgery, and tertiary irradiation. Surgical mortality less than 2%, and case mortality of 4 to 5%. I won't put in the details here, but he thinks that better identification of children at risk for hypothalamic injury is something that we need to continue to work very hard on. And I agree. I think it's not just finding the floor of the third ventricle. Some of these tumors, particularly the complex and the giant tumors, have already perforated the floor of the third ventricle. The sharp spicules of the calcium and the irritant effect of the cyst fluid has already caused significant impairment of hypothalamic function. And no amount of careful surgery is going to stop the progression of such an injury over time on children with this dreadful condition. The 10 and 20-year survival and quality of life comparison between radical surgery, radiation, and multimodality therapies must continue, and we must continue to look for what actually helps and what can be changed. And the upcoming molecular targets for adjuvant and neoadjuvant drug therapy that Todd himself is carrying out research, and I applaud him on that. We must continue to look at that, because that is another modality for the surgeon to use in improving his outcomes. And finally, I just wanted to tell you what's happening in the UK. So the new UK craniopharyngiomas guidelines are coming up. We've been working on those since 2017. My colleague Conor Malucci is leading on this with a lot of my UK neurosurgical colleagues. There is a guideline development group, which is an international group. And I'm also pleased to tell you that Jeff Wissoff and Todd are both part of the guideline development group, or the Delphi consensus group. So what we've done in the UK now is that the guideline development group identified guideline objectives. Objectives then were summarized as PICO questions. Objectives and PICO questions were then reviewed by stakeholders. A systematic literature review was carried out. The quality of evidence was then appraised using the grade system. And then what we did is a two-arm recommendation strategy. On one hand, where evidence was available, we provided that evidence and the quality of that evidence. Where evidence was not available, we used a Delphi consensus process to support experts' views on this. And recommendations supported by more than 70% of the consensus group respondents were then included. And then we had the finalized recommendation reviewed by the guideline development group. and the guidelines where they're put forward. And this is, just to give you an idea, this is not published yet, and I apologize for the way I borrowed the slides from Connor, just to give you an idea what's happening in the UK. There is consensus on a number of areas, but in selected cases where there's potential doubt about diagnosis or extended classifications, CT scan should be performed as a useful adjunct to MRI in the diagnostic workup. Strong recommendation, low quality of evidence. A routine assessment of extended hypothalamic involvement should be performed and recorded prior to surgery at MDT. Strong recommendation, high quality of evidence. The Paris grading system is reproducible and we would recommend its usage prior to surgery. Strong recommendation, high quality of evidence. So this is how we're working, for example, in the radiology. Then when it comes to vision, minimum visual assessments, I'm just going to jump the slide because I don't want to take too long. I want to show you this. Overall management, the policy of management of craniopharyngiomas in tertiary pediatric specialist centers with age-appropriate hypothalamo-pituitary MDT support. That means neurosurgery, radiation, oncology, endocrinology, all of that put together and we may even get adult specialists, strong recommendation, but low quality of evidence. So craniopharyngiomas should be managed in the context of MDT with evidence suggesting that overall outcome is improved when surgery is performed by a surgeon with specific experience in pediatric craniopharyngioma surgery. Strong recommendations, and so on and on. So what we're looking for here is that we try to use a two-pronged approach. We look for quality of evidence. Where we find it, we report it. When there is low quality, we say it's low quality, but the recommendations in many areas is strong. Now we need to go and get the evidence. For example, for large mixed cystic solid craniopharyngiomas or hydrocephalus, a two-stage approach involving minimally invasive surgery with appropriate drainage and resolution of hydrocephalus should be considered, followed by repeat neurological assessment before attempting definitive surgery. So I think this is something that we all do, but there is very weak recommendation and very low quality of evidence because we haven't collected the evidence. In the presence of hydrocephalus secondary to a craniopharyngioma cyst, primary cyst drainage is preferable to insertion of a ventricular peritoneal shunt. Yes, consensus. So that's where we're going at the moment. In radiotherapy, we do not recommend upfront radiotherapy of a confirmed complete resection of pediatric craniopharyngiomas. Strong recommendations, very weak quality of evidence. Close observation for tumor progression rather than immediate radiotherapy is appropriate in selected cases of patients with residual solid tumor following surgical resection. Consensus. So as you can see, and I don't want to undermine any of the things that Todd has said. What we're looking here is an attempt for us to understand the disease better, an attempt for us to move forward, to come together and say, well, okay, let us have a standard operating protocol for this dreadful disease with, very difficult outcomes, no matter what you do, and then try and get more evidence and more consensus on what we're doing. I'm going to try and finish now with a quick review of this very important paper. Some of you have already seen this. It came out in the European Journal of Endocrinology in 2017, Tan and colleagues. This is the compilation of 3-center data from the UK, 185 cases, a 40-year metadata analysis, I think probably the largest in the world. And what we looked at here is 3 centers and dividing, essentially was to look at the traditionally complete resection surgery that we all carried out, and then look at on the basis of the new directive of maybe we should try and be more conservative to reduce hypothalamic injury, the information coming out from the Paris group about hypothalamic sparing. So 2 groups were formed, the metadata reviewed over a period of time before 1973, before was a 1973 to 2000 group, 100 patients, 1998 to 2011 group, 85 patients. The first group, of course, was gross total surgery was considered the aim. The second group, the introduction of conservative strategy at each center was the purpose. This is information on the patients, 185 patients, group A. the two groups together. And you can see that complete resection, very few at radiotherapy, only 5. In partial resection, 50-50 at radiotherapy. In limited surgery, the majority went for radiotherapy and some for surveillance. So what were the results? In terms of resection rates, the group B had less complete resections because that was the intention, more partial and limited surgery. And limited surgery means either doing catheters into cystic craniopharyngiomas, putting shunts, aspirations, and things like that, or ventricular peritoneal shunts. The trends reflected the change in surgical approach over time. Then recurrence rates. Now, the interesting thing is that the overall recurrence rate between the two periods did not change, 38 versus 32. Radiation therapy from 28% in A to 62% in B. So when you carried out gross total resection, you hardly ever, only 1/5 to 1/4 of the patients underwent radiotherapy. But with the new approach, it meant that 2/3 of the patients had to undergo radiation therapy. And then morbidity. So the reason why this change in practice from gross total resection to putting the child through multiple revisions, reoperations and radiotherapy was to reduce the effects on the hypothalamic injury, particularly morbid obesity. But surprisingly, there was no effect. So there was no improvement in vision between the two groups, or no difference, no statistically significant difference in the visual outcomes. And more strikingly, no statistically significant difference in the hypothalamic outcomes, particularly postoperative obesity. So the shift towards more conservative surgery did reduce the hormone deficiencies, including diabetes insipidus, but it was not associated with the expected significant reduction in hypothalamic and visual morbidities, which remained a significant challenge. And more effective targeted therapies are necessary to improve outcomes. And this is, again, I'll come back to the elephant in the room. We are doing everything we can. And what are we seeing? No difference. And I think the no difference is very much to do with what is happening with this disease. It's like in myelopathy. You do a decompression of the spinal cord, you do a fixation, but the patient will remain myelopathic and will continue to progress. So I'm not calling a craniopharyngioma patient myelopathic, please don't say that. But I just wanted to explain that the pathology that started well before the patient presented to us, sadly, will continue. And there is some evidence from research that's been carried out now that the craniopharyngioma, although it's not a brain tumor, it produces the senescence associated factors or the phenotypes that trigger inflammatory response, that trigger inducement of paracrine tumors. And so there is a mechanism, a biological mechanism that is ongoing that seems to, that we need to learn more about, and we need to be able to intervene on that. So, okay, I'm going to finish now. So if you have a low risk case, you must consider upfront surgery. You must consider gross total resection, and you must try and avoid giving upfront radiotherapy in those patients. That reduces the risk or damage to radiotherapy. And although I didn't want to go into details on that, I think it's very well known that radiotherapy will cause vascular damage, moya-moya, the loss of pituitary function. All of the radiotherapy patients almost certainly will require long-term hormone replacement. It brings the risk of secondary malignancies. And in the Jeff Wissoff's case, one patient died of a DIPG 12 years after radiotherapy. So, you want to avoid radiotherapy if you can in a low-risk case. If your patient has medium risk, and I'm saying medium risk as something that I'm putting together the Paris grouping as well as the Liverpool grouping, then consider upfront surgery. But the extent of resection is based on surgical judgment. Do a near total or subtotal resection if damage to the nerves or hypothalamus are a real threat. If high risk, consider endoscopic or stereotactic biopsy, drain the cyst, treat hydrocephalus, reevaluate after 4 to 6 weeks after cyst drainage. Is the floor of the third ventricle now visible? If it is, then consider resurgery and attempt a gross total resection. Failing that, you go for the other less favorable options. Upfront radiotherapy only if high risk and solid tumor. Okay, so I think just for discussion purposes, I think we need to think very carefully. Is the strategy that we are adopting, the risk reduction surgical strategy we are adopting, resulting in improvement in hypothalamic damage? I think some studies do suggest that, and the Paris study did suggest that, but a much larger study carried out here in the UK of multiple centers has failed to show that improvement. What are we achieving in terms of vision? What are we achieving in terms of all the other things that the compression of the tumor is causing? So we need to think about the size of the tumor and how do we bring that size to its smallest possible size while preserving the structures around. And then we need to consider increasingly more endoscopic cyst drainage, although there is neither a good recommendation or strong evidence for that currently, but that's the sort of thing that we need to go chasing after now. And gross total surgery definitely is the sort of thing that I would recommend in cystic, intracellular, in prechiasmatic surgery, because these tumors are quite away from the hypothalamus. And those are the ones that we have an opportunity to do some good without doing much harm. Retrochiasmatic tumors already have hypothalamic damage in most cases, and surgery may not be the only reason for the injury. And then reduce the grade, reduce the grade by draining, as I mentioned before. So now coming to the end, I'm going to go back and say, this is a benign tumor. Upfront surgery at first presentation should ideally be our approach. Don't do it. What I'm saying here is I'm not giving a carte blanche for every neurosurgeon in the world to go and do this. You need to be able to work on a multidisciplinary team with the environment which is appropriate to make such a decision. That means you have to have the experience. You need to be your learning curve needs to be at a point where you can confidently propose to the parents and the child a gross total resection with a degree of safety. You need to have in place the support system, the endocrine support system, the oncology system, the radiation therapy system that provides for such an aggressive treatment, and the support, the socioeconomic support to manage the postoperative difficulties that may ensue, particularly the endocrine deficiencies. But radical resection provides a good quality of life, and absolutely experience matters. And the UK centers, Jeff and others have highlighted, we need to go for improved centers that carry more and more surgery so that the learning curve improves. So take-home message is just a summary of what I just said. Consider multidisciplinary work absolutely vital. Experience surgery, centralization, improving surgical techniques. I didn't have time. I intended to put in Professor Diopujari's transphenoidal. He had very kindly shared some slides with me, and also Ricardo's supraorbital approaches. There are many approaches which I believe will add to reduction in complications and improvement in the ability of us to resect this tumor safely. Always consider long-term consequences. Subtotal resection for high risk of recurrences. You can do stage surgery. You don't have to do gross total resection in one go. You can do stage surgery. And like everything in life, the truth lies in the middle. And although I'm here fighting for gross total resection, I'm not here to colonize the United States or Denver. I'll finish by saying, a mistake that makes you humble is better than achievement that makes you arrogant. And I want to thank you for your patience and listening to me. Thank you.
Great job, Guirish.
Thank you. Thank you so much, Guirish and Todd, for the excellent presentation. And now we're starting for some questions for the audience. Todd, I saw that you answered 2 questions. If you want to comment about them. The first is comparing endoscopic approach with the craniotomy, and the other one is what's the best option in low research countries where the endocrine treatment is limited. You can comment your answer?
Sure. So the first question had to do with how does the emergence of extended endoscopic surgery impact outcomes with regard to surgery for curative intent. And I think that endoscopic surgery in pediatric patients has been a real game changer in terms of how we approach these tumors. And cranio, I think, is particularly amenable to transnasal endoscopic approaches, and it's certainly what I try to do first in cases where I can. The problem with interpreting the data that are out there right now is that people understandably started with series of patients that were highly selected because they were amenable to that approach. And by definition, those are going to be tumors that sit a little bit lower, which is going to take them further from the hypothalamus, which is really where the sort of key site of morbidity occurs with these tumors. So I think you're going to have a tendency towards more favorable outcomes because your patient selection directed it that way in those series. So I'm not arguing that we should try to do highly complex hypothalamic involving through the nose so that we can learn whether we hurt people or not. But I think that you need to interpret those series with that in mind. That being said, the visualization through a transnasal approach is really outstanding. I'm not sure necessarily better than if you're doing a transventricular and looking at the hypothalamic wall through an endoscope that way, but it really is, I think, in my hands, I like that approach. The second question had to do with approach in low resource countries, and I think that that's a real challenge. And the reason is that the most effective anti-tumor approaches that we have, which are aggressive surgery and radiation, those are both associated with very high rates of endocrinopathies and hypopituitarism, and that's what we're talking about having trouble managing in those situations. So I think there you really need to think about trying to be conservative operatively to avoid causing unnecessary endocrinopathies early on, diverting CSF when you need to, and then trying to leverage the fact that these are relatively slow-growing tumors in most cases, and deciding how to proceed based upon the details of the situation there.
Thank you. So in fact, I have some consideration that you listen your presentation. So first of all, craniopharyngioma is a chronic disease. We need to understand this at the beginning and try to figure out how we manage in different steps the treatment. So in one way, you have the possibility of cure if you do for the gross total removal versus the morbidity and quality of life. So these 2 points balance the treatment. We also have another very interesting point when we consider the papers published in on the literature is how they select the patients, because we have two different diseases from the pediatric group and the adult patients. So both are completely different in terms of long-term result, endocrinological problems. So these need to be considered when you analyze a paper. Another two questions for both speakers. So one, Todd, you talk about molecular targets and new therapies. We also have some expectation of this. So we have expectative and the reality. So in your opinion, when you look those different treatments or those different research concerning craniopharyngioma, in your opinion, how is the most close to the reality for us?
So in terms of new therapies, I think that in the next year or two, there should at least be the opportunity to evaluate some of those through the clinical trials that I mentioned at the end there. You know, those, in terms of being close to a reality, you know, are not that far away. What I would say is, I don't know what the results of those studies are going to be, and they may not be that effective. One of the things that really handcuffs us, and where people like John Apps and JP Martinez-Barbera are really moving things forward, is that we don't have really good models to try to study this tumor. And as a result of that, the data that we're relying on to inform these trials, so the data that supports the use of MEK inhibitors, for example, or the use of IL-6 inhibitors like tocilizumab, that's pretty thin data. Now, we have used those drugs in a handful of patients, and in many of them had encouraging results, but it's not like the tumors magically disappear. It's just they're controlled. But they've been used in patients. We're evaluating sort of initial groups, and in the next couple of years, I think there really will be some opportunity in centers that have these trials open to actually treat patients. How quickly that swings the pendulum, or if it does at all, in terms of how we as the multidisciplinary and surgical community address these patients at the time of diagnosis, is hard to say. And I think it will be a number of years before we really have, you know, what's hopefully curative treatment right off the bat. But I do think things are moving along relatively quickly. For the majority of patients who aren't at centers where we can do these trials, it's going to be what we've talked about. It's going to be, you know, GTR, STR radiation, intracystic therapies, and how we balance those, you know, for the next few years for sure.
Yeah, I think, you know, many years ago when, you know, interferon therapy came on, we were quite excited about it. And we thought, yeah, this is going to treat it. Because at that time, I think many people thought, and I was one of them, that, you know, craniopharyngioma not being a brain tumor, it's probably more inflammatory cascade resulting from the cholesterol crystals. And for a period of time, that was something that a lot of people got involved in. It helped kind of dry up the cysts to some extent. So you avoided having to reaspirate the cysts, the patients having to come to the hospital and so on. But in fact, it's not a cure for craniopharyngioma. It delays the treatment of the solid tumor. It's only effective in drying up one single cyst. You can't put 4 or 5 different catheters. The cyst has to be of a large size. So I think more and more that probably is not a long-term option in treatment of craniopharyngioma. The other thing is, and I absolutely agree, and I congratulate Todd on getting involved in some of the research that's going on. John Apps is one of the researchers in our hospital at the University of Birmingham. He's shared some of the research with us as well. But I think the exciting thing is this is emerging technologies, and this is for probably 5 years' time. You know, some good stuff will start coming up that we might be able to use in therapy for children. But right now, I think all we can say is, yeah, beta-catenin. You know, we are learning the pathway of the pathology, the formation of paracrine tumors. And then once we know that, then targeted therapies can start coming up. The MEK inhibitor is definitely one area of research. Others, of course, will be the genetic unraveling of this, you know, craniopharyngioma. And once we are able to do that, then we'll be able to start targeting biological therapies better.
Okay. Guirish, it's very clear for me when you see your presentation that you gave a very important talk, is how you select your best candidate for surgery. So it's very clear for me in your presentation. And so both speakers, and you can answer some questions for the audience. So when we talk about radiotherapy, if you pay attention, comparing the standard radiotherapy versus proton beam radiotherapy. So it's not easy for the most countries have proton beam because it's too expensive for us. So in your opinion, how you manage the indication of radiotherapy? When is the best moment to indicate radiotherapy? And in which case you indicate radiotherapy?
So that, Ricardo, thank you for asking that question. That's a very important question. It's been something that, has been worrying us. So it's all in good for us in developed countries to make guidelines about treatment. But a lot of the guidelines cannot be followed in the rest of the world. In many countries, say in Africa, there are no radiotherapy centers, much less specialized radiotherapy centers that can deliver proton therapy, for example. So when it comes to that, you are only left with one option. You either do nothing, or you do limited surgery. That means treat the cysts with catheters, or carry out surgery to remove the tumor. Now, of course, you will have to balance this. And I, of course, would hate to be in a situation where I had to provide substandard treatment. But if you if you're too aggressive, then you're going to create two problems. One will be the endocrine dysfunction, and the other is the possibility of, unmanageable hypothalamic injury. If you, on the other end, leave the tumor to progress without interfering, then the patient is inexorably going to suffer all the things that you are afraid to cause by your surgical action. That means the patient is going to go blind because you did not act in time to prevent decompression and decompress the optic chiasm. You continue to do nothing because you're afraid that if you do something, you're going to damage the patient. Then the patient will get hydrocephalus and will die of hydrocephalus, or will have some standard, will suffer from the ravages of delayed treatment of hydrocephalus. You continue to do nothing, and the patient will develop the hypothalamic injury that you are trying to avoid by surgery. You continue to do nothing, and the patient will develop diabetes insipidus, and will suffer all of the endocrinopathies that you are afraid to cause by surgery. So inaction, I think, is something that we should not consider. And for those who might think that, no, the patient does not develop any of this without surgery, actually my very first patient, my very first brain tumor patient in my whole life was a craniopharyngioma. I was doing philanthropic work in South America, in Guyana, and I admitted the patient. I thought it was cerebral malaria. And suddenly it dawned on me that this patient had diabetes insipidus. And then I did an X-ray of the skull and found suprasellar calcifications. And this patient had already developed all of the endocrinopathies that we are worried to cause by surgery. And of course, the patient then underwent surgery and other things. But the point is, the disease itself will cause all the things we're worried about. So I think I would say, even if I was in a place where radiotherapy was not available, I would consider surgery. If the tumor was a type that could undergo gross total resection, then the important thing here is who is going to do the surgery. And if the surgery can't be done safely and expertly in the place where the patient is, then by God, you must try and see whether we can send this patient somewhere where the surgery can be done. Even if no further radiotherapy, other things are possible, but at least optimize the opportunity to protect this patient from further harm by creating a situation where surgery can be carried out somewhere.
Okay, would you just comment something, Todd, Sandeep, about radiotherapy?
In terms of the proton versus photon discussion?
Yeah.
That's definitely a tricky one. And I think that opinions really vary based on who you talk to. My interpretation of the literature right now is that most of the advantages associated with proton really are in more of the theoretical space than the true clinical outcome space. The group at St. Jude has tried to do some modeling to see if there are potentially some cognitive or memory advantages with proton versus photon. But really, I think right now there aren't convincing data that proton is superior from a risk standpoint in the context of craniopharyngioma management. So, you know, the morbidity and side effects associated with radiation are obviously really critical to the decisions we make with regard to how aggressive to be with surgery. But I'm not sure right now that the data separating proton and photon is robust enough to choose one over the other definitively, especially with the added cost and inconvenience that can be associated with having to send a patient to a proton center.
If I may ask a question, Ricardo, with your permission, you know, I think one of the big problems of the literature available is that there is a group that has assessed them purely from the craniotomy aspect, for example, Paris. There's another group, like in Pittsburgh, that have looked at it completely from the endoscopic aspect. Now, whether you go up the nose or whether you do a transcranial procedure, do you think that there is a fundamental difference in the risk of hypothalamic injury or injury to the pituitary stalk, whether you go at it from above downwards or from below upwards? This is the first question I have to both the panelists, because both of you do both procedures. So I think one of the big problems is that we've mixed up the literature of the craniotomy approaches with the endoscopic approaches, and therefore there is more confusion as to how aggressive we should be. Do you think there is a fundamental difference in the risk of pituitary stalk or hypothalamic injury in transcranial procedures vis-a-vis endoscopic procedures?
That's one thing that maybe we'll hopefully get some insight to with the outcome data from our North American group, because the data we're accumulating is in centers that do both, and it's in patients who have received both. So maybe we'll have some comparative data to look at that. But it is a good question. I think that when I think about if there's less risk with a transnasal, I think about, so why would that be? And the only answer I can better visualization of the relationship between the tumor and the hypothalamus when you can put a scope up so you're very close to that tissue and you can inspect those tissue planes more carefully. So you can see it better than you can through a pterional. I think that someone who's really experienced with a pterional approach may very well be able to see and feel comfortable that they can identify those relationships just as well as they could with a scope through the nose. So I don't think that there is an inherent difference other than how well you can visualize it and what your particular skill set is. I think in my hands, I'm probably more comfortable. I can see it better with a scope transnasally. I don't know if that would translate into better outcomes. I think it's really hard to tease that out because now you're testing two things. The inherent characteristics of the tumor, which I think Guirish has really talked about, you know, the tumor itself causing injury regardless of what we do, and do we sort of underrepresent that in our data? So that variable is there, and then the variable of how well I can see in a pterional versus transnasal. So that's going to be a difficult thing to really tease out, but to me, that's the only reason why one would be better than the other. I think with regard to pituitary dysfunction, pituitary stalk, I don't think there's a difference there. You know, you could argue that you're blind to the pituitary stalk more so with a transnasal than you are coming from the side with a pterional or from the front with subfrontal. But I think that there you're going to be about the same.
Guirish, you agree with that?
In part, I think, you know, what's happening is just like everything in surgery. You know, as we advance surgery, we tend to become less invasive. And being less invasive means less trauma or damage to surrounding structures. And I think, at least in my experience, I've encountered craniopharyngiomas where I was not able to completely remove them by a cranial approach. And I'm not a anterior skull-based surgeon, and the only experience I have is when I was a trainee, rather than, although, you know, having done the course and so on, I understand what we're talking about. And so people like, you know, ENT surgeons and my neurosurgical colleagues that perform anterior endoscopic transsphenoidal surgery certainly help. And I've often asked for their opinions, and we have multidisciplinary discussions on this. And when they can help, we do combined approaches. And combined approaches means gross total resection of the tumor without upfront radiotherapy, without the hypothalamic injury. And I think for certain, I would agree with Todd about the pituitary or the endocrine dysfunctions. I don't think transfemoral surgery will reduce those, but it may, the advanced or the expanded transfemoral approach, which Chandrasekhar Deopujari has also championed. And if he's here, perhaps we could invite him to say a few words about this. But the expanded transfemoral approach gives a much better visualization of the area inferior to the floor of the third ventricle, which is the point in question here is, how can we stop hypothalamic injury? So and through transcranial approaches, we can't really see that area as well. So if you do an interhemispheric approach, you're coming from above, you have to go through the hypothalamus. If you're doing a terrenal approach, you may be able to see one side of the area. Subfrontal approach provides probably the best visualization, but not enough to go below the posterior clinoid. And here, in the transfemoral approach, you get that vision. And remember, the craniopharyngioma in its majority would have the dura and the subarachnoid in between the floor of the third ventricle. So it's only the craniopharyngioma that has already perforated the layers and has gone through the floor of the third ventricle. In those cases, I think the chance of preserving hypothalamic function is 0. But in other cases, we may be able to debulk the tumor more successfully through a transfemoral approach. And certainly I would consider combined surgery, both in terms of visualization and in terms of potential preservation of hypothalamic function.
Okay. Yes. Just a comment in your question, Sandeep, about endoscopic approach and craniotomy. I think that when we talk about craniopharyngioma, we need to have an open mind. We need to understand that there are different approaches in different moments, and you need to talk with other colleagues to have a good point. It's important how Guirish point out is to have a multidisciplinary team to discuss the best treatment in that moment. When you consider the endonasal, it's in pediatric patient, it's a little bit difficult because you have some challenges as an anatomy. Sometimes we don't have a sphenoidal sinus open, so it's another complication. The other problem is when you have a midline tumor or a midline and paracellular tumor, so it's another complication for endonasal. So I think that you need, when you are ready to treat craniopharyngioma, you need to be open mind. So you need to be ready to listen and to understand that there are different options, several approaches, and you need to dominate them. So in my opinion, you don't need to be closed, I will do only pteronal approach, or I will do only something. So you need to be open mind. So Sandeep, I think that if you have another comment.
No, I think we're getting to the end of time. I just say one last thing, and that is, the children with craniopharyngiomas that really worry me are the ones that have a craniopharyngioma where I've left behind some significant residue and thought I'll just watch it and then give some adjuvant therapy like the panelists have discussed. And I've watched them and watched them and watched them for years, and they haven't grown at all. And this makes me worry about the ones that we've tried to take everything out and cause some amount of endocrine dysfunction or pituitary dysfunction. I wonder, how do we predict which is this subgroup that doesn't grow that fast at all? And I think the real answer to the solution of craniopharyngiomas in children will be if we can find this group so that we are limited in our resection, and then we just watch them, and we know these don't grow. And all of us have these kids that have got a big mass of calcium and a little bit of solid tissue sitting there in the suprasellar region, and we're watching them for years into adulthood, and it never grows, and they never have a problem. And which makes you worry that the ones that you really tug at and try and take everything out from that area, whether you're doing them good or harm. On the other hand, of course, there are other ones that you leave behind that grow and come back in about a year. And then you have to sometimes go back and do a second look surgery, as Guirish pointed out. And I think the sort of molecular work that Todd was talking about would probably give us an insight into which of these tumors can we be less conservative and leave alone, a little bit like the work on medulloblastomas. And maybe that will be the future. I don't know. I mean, what's your last opinion on this before we close?
So I agree with you. I think my feeling on that is that a combination of sort of multimodality research, I think aided by machine learning analysis of the large volume of data that it produces, may help us identify patterns and predict. So look at not only the biological data, but correlate that with neuroradiological data, with clinical outcome data, and then be able to analyze that through machine learning algorithms to say, hey, a patient with this combination of factors has a low likelihood of having rapid growth of residual tumor. And we're still a few steps from that, but I think we're heading in that direction.
Yeah,
you guys are trying to do exactly that with your UK study.
Yeah. Yeah, I think I agree with what you said. I think we should look at particularly when solid tumors, you always worry. I mean, at the moment, my impulse would be to, if I left something behind, is to repeat the early scan and see whether there's changes in growth or anything like that. If there's no changes in growth, then maintain observation and only consider radiotherapy subsequently. The new modalities, I think, is going to take some time. We'll just have to wait and see. A lot of research has to be done first before we get there.
Right. Well, I think that brings us to the end of a remarkable debate. And I think the biggest take-home message of a debate on craniopharyngiomas is that we all have to agree to disagree as to what is the best management. But it's been a great debate. And thank you very much, Ricardo. Thank you, Guirish. And thank you, Todd, for sparing your time for this fantastic Clash of the Titans. Just to tell you, the next educational activity of the Education Committee of the ISPN is to run its first ever virtual educational course. And on the 1st and 2nd of March, the Education Committee of the ISPN will be running the Russian pediatric neurosurgery course just 2 days before the annual conference of the Russian Society of Pediatric Neurosurgery. This will be a virtual course and will be the first of its sort that is being run by the Education Committee. We hope if we start with virtual courses, as we progress down the year, we'll soon be able to get to physical courses in the second half of the year. And on that hopeful note, we'll bring this evening to a close. Just to remind you, the next Clash of the Titans will be exactly on the same date, the 12th of the next month, because February has 28 days. So it'll be Friday, the 12th of March, and we'll keep you in suspense as to the topic and the speakers for now. So wherever you are, good morning, good afternoon, or good evening. Have a great day.